Well, good evening, everybody. I hope you all are there with me. Wish you all a very, very good evening, guys. Good evening, Prakha Tiwari Saab. Good evening. Good evening, SMS. Abhishek, my, all the favorite champs are here. Good evening, Abhishek, SMS, Tiwari Saab. So, okay, guys, we are here and we'll start with our session, which is Thursday 10 session. Shubham, Abhishek, all my love to you, buddies. So, Thursday 10 sessions. So, in this session, good evening, Zubair. So, in this session, we'll discuss yes, Pranav, you're right. So we'll discuss the 10 main important pathologies, MCQs from the entire pathology, taking general pathology, considering hemat and the systemic one. So, right, we'll give a time, read the question carefully, answer, and then we'll discuss the points. Okay. So that is there, the first question right in front of you, Baba. Read the question carefully. It has been asked in that pattern only. Read the question whether they're asking about the correct one or the except one. Waiting for your answer, guys. Waiting for your answers. Good evening, Upendra. Good evening, Patra Saab. Yes. So they are asking the correct statement. Abhishek has made an answer. Shubham has made an answer. Abhishek has gone for C. Abhishek, Shubham has gone for C. The answer is which one of the following is a correct statement regarding aging? Yes. So the answer is Upendra has come for the B. Answer is people are going for A, C, D. Very good, Pashupati. Very good. Very good, Pashupati. Yes, you are the only one who's made a right answer. Guys, why C? DNA dependent RNA polymerase, telomerase. Come on, guys. Come on. Telomerase is a reverse transcriptase. Telomerase is a reverse transcriptase. That means it must be RNA dependent DNA polymerase. It has to be RNA dependent DNA polymerase. Please don't mistake this, put this mistake in the exam, man. It is not DNA dependent RNA polymerase. The telomerases are actually reverse transcriptases. Now you got it right, Shubham. So telomerase are not DNA dependent. I know most of the people will go with C. Very good, future doc. Please make sure you don't do this mistake in the exam. So telomerase are not DNA dependent RNA polymerases. Telomerases are reverse transcriptases. These are RNA, put right in the block letters, right? This is how they will trap you in the exams. So RNA dependent DNA polymerases. So C cannot be the answer, guys. See, they're asking the correct statement here. C cannot be the answer. Yes, now you're getting it all right. The answer is D. The answer is D. I repeat, sirtuins aging is one of the hot topics for the exams, right? So, okay, the answer is D. First of all, everybody, why first statement is not correct? The normal human cells are capable of 60 to 80 times. What is the Hayflick limit? Come on, tell me. What is the Hayflick limit? It is a normal cell can divide for 40 to 60 times in its life, right? So we all know that this Hayflick limit, it is not 60 to 80, it is 40 to 60 times, and this limit is called as Hayflick limit, right? So Hayflick limit is the number of times a cell can divide in its entire lifetime, and that is average 50, so 40 to 60 times, right? So after that, what will happen? We all know, after 40 to 60 times dividing, yes, there will be increase in activity of, so there will be shortening of telomeres, there will be shortening of telomeres, and that will lead to aging, right? And that will lead to aging, right? So after 40 to 60 times the cell will divide, there will be shortening of telomeres leading to aging. So the Hayflick limit is not 60 to 80, it is 40 to 60 times, right? And average is 60, right? 50. Now next point, sirtuin decrease insulin sensitivity and glucose metabolism. No guys, sirtuin will increase, sirtuins will increase insulin sensitivity and glucose metabolism. Sirtuin will increase insulin sensitivity and glucose metabolism. Come on guys, come on, tell me the function of sirtuins. Tell me the functions of sirtuins. So remember sirtuins, no confusion. भैया मैं कह रहा हूं sirtuin से मांग लो माफी, सर से मांग लो माफी. So just remember, if you know, very good, otherwise there should not be any confusion. सर से मांग लो माफी, right? MAFI, that is the function of sirtuins. Now M stands for, right, there will be decrease metabolism. First three will decrease. M for decrease overall metabolism. A for decrease apoptosis, A for decrease apoptosis, F for decrease free radicals. So first three are decreased here, so that will be easy. First three are decreased: decrease metabolism, decrease apoptosis, and decrease free radicals. Now I for increase, I for increase in insulin sensitivity, I for increase in insulin sensitivity, and of course insulin sensitivity will increase, that will increase the glucose metabolism. So remember, sirtuins increase metabolism, glucose metabolism, but overall metabolism is decreased by sirtuins. So maafi, sir se main tumhara sir hu, mujhse maang lo maafi. So remember, sirtuins are metabolism decrease, apoptosis decrease, free radicals, but increase in insulin sensitivity. और अगर तुमने सर से माफी नहीं मांगी, if you don't ask for maafi from sir, what you'll get? Come on, what you'll get? You will get coronary artery disease, guys. You will get coronary artery disease. Will not ask maafi from sir, you will get coronary artery disease. That means three things that sirtuin is associated with: C for cancers, A for aging, and D for diabetes mellitus. So it is used in treatment of these three conditions: CAD, cancers, aging, and diabetes mellitus. So we all know, because sirtuins increase insulin sensitivity and increase glucose metabolism, they are used in treatment of diabetes mellitus. So remember this mnemonic: sirtuins, sir mang lo maafi, that will be the functions, and otherwise you will get coronary artery disease, CAD. So maafi and CAD. So sirtuin is used in the treatment of cancer, aging, and diabetes mellitus, and the function is maafi. Clear? Okay guys, okay, so repeat this question. The answer would be D, where they have written that sirtuins increase insulin secretion and is implicated in diabetes. So right, that would be the correct statement. Okay guys, so first question done. Okay, now coming to the second question, guys. Coming to the second question. Chalo, answer. "55-year-old man, symptoms of COVID-19, RT-PCR was positive for COVID-19, but the point is here, increase in the level of C-reactive protein. Increase in the level of C-reactive protein. So all of the following are correct about C-reactive protein, except which one of the following is not a correct statement about sirtuins? शुभम तो मार खाएगा मेरे से. They are asking correct except. Which one is not a correct statement? HSCRP is used as a marker of future coronary artery disease. Is it a wrong statement? क्या कर रहे हो मेरे भाइयों? Very good future doc. Very good guys. शुभम तो मार खाएगा, अभिषेक तू भी डांट खाएगा मेरे से. Come on, the answer is शुभम अब D, C से A पे आ गया, अभिषेक भी A पे आ गया. Acha, if A is not the correct statement, can you tell me what does C stands for? What does C stands for? C-reactive protein? But it is a right statement. It is a correct statement. C in C-reactive protein stands for capsular polysaccharide for pneumococcus. That is a correct statement. One of the old NEET MCQ where they asked, what does C stand for? So C stands for capsular polysaccharide. Very good, Bhavna. Very good, Zubair. Zubair, Bhavna, very good. Vicky. यहां पे कर दो गलती बेटे, वहां किया तो तुम्हारी रीढ़ की हड्डी और मेरा मुक्का. Don't make this silly mistake in the exam. So C in first point, just write it down. C in C-reactive protein stands for capsular polysaccharide for pneumococcus. That is the correct statement. Second, C-reactive is a protein, is a positive acute phase reactant. Yes, guys. Why? First of all, what are the reactants, or what is the definition of positive acute phase reactants? Positive acute phase reactants are those reactants which increases by 25% of the normal level in inflammation. That is the correct definition, man. That is the correct definition of a positive acute phase reactant. A positive acute phase reactant is a reactant whose value increases by more than 25% in inflammation. So that is the correct statement. And C definitely is a correct statement, man. Absolutely, man. Absolutely right. So increase by 25%. Future dog, just remember this value. So increase by 25% of the normal values, then you call as positive. And yes, highly sensitive C-reactive protein is now used as a future marker of, is a marker of future coronary artery disease. I'm sure you must have studied this in medicine also. So that is also a correct statement. So what is the wrong statement? C-reactive protein along with albumin is a negative phase reactant. No, guys. C-reactive protein is not a negative phase reactant. It is a positive phase reactant. That is why the second statement is the correct one. So C-reactive protein, good evening Yogesh, is a positive phase reactant, not a negative phase reactant. So now just come on, tell me now. Come on, tell me all the acute phase reactants that you know, both the positive and the negative one. Positive and negative acute phase reactants. Come on, tell me. So positive and negative. अरे भैया तुमने लगना एमडी कर लो, एमडी नहीं करोगे तो गवर्नमेंट जॉब करनी पड़ेगी, और गवर्नमेंट जॉब कर ली ना तो भैया पीएससी सीएससी पे नौकरी लगेगी. एंड इन पीएससी सीएससी इट्स एन हॉरिबल प्लेस टू वर्क, मैन. राइट? नो शुभम, नो. सो पॉजिटिव एंड नेगेटिव. सो रिमेंबर, पॉजिटिव का निमोनिक है. मैं कह रहा हूं पढ़ लो, एमडी कर लो, नहीं तो गवर्नमेंट जॉब में एमओ करोगे जहां पे पीएससी सीएससी पे जॉब लगेगी और वहां पे बहुत गंदगी होगी. इट्स अ वेरी हॉरिबल प्लेस टू वर्क, वेरी फिल्थी प्लेसेस. तो रिमेंबर, अगर तुम वहां लगो भी तो सफाई रखना भैया. पीएससी सीएससी पे सफाई रखना बॉस. पीएससी सीएससी पे सफाई. पीएचसी सीएससी SFA1. सो पी स्टैंड्स फॉर प्रोकैल्सिटोनिन. आई एम टॉकिंग अबाउट द पॉजिटिव मार्कर प्रोकैल्सिटोनिन. H for hepcidin. H for hepcidin. C for ceruloplasmin. Another C for C-reactive protein. H for again highly sensitive C-reactive protein, and we have this haptoglobins, haptoglobin levels. Now one more C for the complement proteins. Complement proteins. S for serum amyloid associated protein. Abhishek, just a mnemonic, Baba. Abhishek Baba, PHC, CSC, Safai. Just a bit of Hindi mnemonic to it. PHC, CSC, and F for fibrinogen. F for fibrinogen, also ferritin. Also you can add ferritin, and A1 for Safai, A1 for alpha-1 antitrypsin. So now make sure you don't make a mistake in the exam. So mnemonic for the positive acute phase reactants are PHC, CHC, Safai, SFA1. A1 means alpha-1 antitrypsin. So remember, all these are the positive acute phase reactants. So all except questions, one of the favorite topics. Make sure you don't make mistake in this exam. So all except questions, remember all this mnemonic, right? So these are the positive acute phase reactant. Now about the negative. Can you tell me about the negative? अरे भैया एक पत्नी से पूछो, ask any wife that who is the most negative person in their life. A wife will say, मेरा पति. So मेरा पति is the most negative person. So remember, Samad, we are discussing the entire 10 important pathology MCQs. So negative is pati. The most negative person for a wife is pati. So remember, P for pre-albumin. Pre-albumin, A for albumin, A for albumin, T for we have 2, we have transferrin, and the latest, the Robbins 10th edition, they have added thrombopoietin. So thrombopoietin and transferrin, and I for insulin-like growth factor 1. So make sure, man, right? So pre-albumin also called as transthyretin. It is same thing only, pre-albumin and transthyretin. So remember, negative is Pati, right? So pre-albumin, albumin, thrombopoietin. This is the latest Robbins 10th update. So make sure you know this. Thrombopoietin is one of the negative acute phase reactant and insulin-like growth factor 1. Ab mat galti karna. Now don't make a mistake. So positive is PHC, CSC, Safai. Negative is Pati. Pre-albumin, albumin, thrombopoietin, transferrin, and insulin-like growth factor 1. Clear? अब कोई doubt नहीं है? I hope it is sorted out now. Okay, guys. Now, next move to the next question. Right? I hope you have written it. So we'll move to the next question. Right? Okay, guys. Chalo. Read the question carefully and make a right answer. So you have to match the following. Come on. One question, 4 topics will be discussed. So make sure you know this. Very good, Pashupati. I'm glad at least you're responding. Sid, Zubair C, Sid D, Abhishek C. Very good, guys. So very good. Now most of Pranav and Sid, you have made a mistake, buddies. So okay, match of the following. First of all, Gaucher's disease. Very good, Jhansi. Very good, Abhishek. Very good, Pashupati. Very good, Zubair. Very good, Jhansi. Okay. So come on. Gaucher's disease. We'll have Gaucher cells. We all know, right? Very good, Shubham. So Gaucher's disease will have this pass positive material with fibrillary cytoplasm. And we all know this fibrillary cytoplasm is nothing but, what do you call it? Crumpled tissue paper cytoplasm. We all know these are crumpled tissue paper cytoplasm. So Gaucher's disease will have, very good Shri, very good Pranav. So Gaucher's disease will have pass positive material with fibrillary cytoplasm. So they have not used the word directly crumpled tissue paper cytoplasm, but we all know crumpled means again this fibrillary cytoplasm only, which is a pass positive material, right? Okay. Now Niemann-Pick disease. What will have in Niemann-Pick disease? Very good, zebra bodies. We all know Niemann-Pick disease will have zebra bodies. Very good, guys. Very good. So Niemann-Pick disease will have zebra bodies on electron microscopy. Zebra bodies electron microscopy. And Tay-Sachs disease, again on electron microscopy, will have myelin figures. Tay-Sachs disease will have myelin figures on electron microscopy, and CML will have pseudo Gaucher cells, which are nothing but C-blue histiocytes, which are positive for osmium tetraoxide. So remember, you know the names also, right? I know that they will not ask this easy, but make sure if they are a little bit in angry mood, they will ask the name of the stains. So osmium tetraoxide is for the pseudo Gaucher cells, whereas PAS is for the Gaucher cells. That is the Tay-Sachs disease. So quickly revise, right? So first of all, the Gaucher cells, we all know, guys. So we all know about these Gaucher cells. This fibrillary cytoplasms. There is presence of this fibrillary cytoplasm. And what is the reason for this fibrillary cytoplasm, guys? What is the reason for this fibrillary cytoplasm? It is because of the lipids in the lysosomes. The lipids, because of the glucocerebrosidase deficiency. We all know there is deficiency of glucocerebrosidase in the Gaucher's disease. So lipids will accumulate in the lysosomes of the cells, right? So lipids will accumulate in the lysosomes of the cell. Because of this fibrillary cytoplasm is seen. And now remember, right? Because similar cells are also seen in CML. Similar cells are also seen in CML, and there you call these cells as pseudo Gaucher cells. There in CML, because of the high turnover, you call these cells as pseudo-Gaucher cells. You call these cells as pseudo-Gaucher cells. So similar structure can be seen. So how do you differentiate? Remember guys, the Gaucher cells are positive for POP. The Gaucher cells are positive for POP. You do POP in the house, right? So POP. P for very, very important is the Prussian blue stain, all the pearl stain. So P stands for the Prussian blue stain. O for oil red O. O for oil red O. And P for, I already told you, the PAS stain. So remember the Gaucher cell, because Gaucher and pseudo-Gauchers both can have this C blue histiocytes. Both can have this fibrillary cytoplasm. So remember it is a stain. So Gaucher is positive for POP, Prussian blue stain, the pearl stain, oil red O and PAS stain. Whereas the pseudo-Gaucher cells, they are positive for the phospholipids. We all know, right? Pseudo-Gaucher cells are formed because of high turnover, where the cell will very rapidly die. So when the cell will die, the phospholipids of the damaged cells, are positive for osmium tetraoxide. They are positive for osmium tetraoxide. So remember, pseudo is awesome, pseudo or Kamal. So right, remember Kamal is CML is Kamal. So Kamal is awesome, man. So CML, we all know CML, pseudo-Gaucher cell. So it is awesome, osmium tetraoxide. Kamal is awesome. So CML is positive for osmium tetraoxide, whereas Gaucher cells are positive for POP, Prussian blue oil red O cytoplasm, right? So Prussian blue and oil red O cytoplasm. So this is very, very important image, this is the Gaucher cell image. So remember the history, CML history, pseudo-Gaucher cells, Gaucher's disease history, think about the Gaucher cells, and pathology wise, stains are very, very important. Now coming to these two stains. This is Niemann-Pick disease, man. The two very important images for the Niemann-Pick disease. So remember in Niemann-Pick disease, on the light microscopy. So we all know there is sphingomyelinase deficient. So all the sphingomyelin will accumulate in the cells, and because of this, you will have this multiple small vacuoles in the cells. So multiple small leading to this foaminess. You see all this foaminess. So Niemann-Pick disease will have this multiple small vacuoles in the cells, giving them appearance of this foamy cells, right? So on the light microscopy of the Niemann-Pick disease, you will have multiple small vacuoles. So multiple small vacuoles, again because of the sphingomyelin accumulation in the lysosomes, you will have this multiple foamy cells, multiple vacuoles leading to this foamy cells. So remember, Gaucher cells light microscopy for Gaucher's disease, Niemann-Pick disease light microscopy is presence of these foamy cells, this foamy cells, and on the electron microscopy, on the electron microscopy, you will have this zebra bodies. On the electron microscopy of the Niemann-Pick disease, you will have this lamellated configurations. You will have this lamellated configuration, because of which you call it zebra body. So remember, Niemann will pick what? Pick zebra. So don't forget. So Niemann will pick zebra. So zebra bodies are seen in the Niemann-Pick disease. Remember, so crumbled tissue paper chromatin, Gaucher's disease, zebra bodies is seen in the Niemann-Pick disease. Now myelin figures. Talking about this myelin figures, just remember guys, this multiple myelin figures are seen in Tay-Sachs disease. They are seen in Tay-Sachs disease. So multiple myelin figures are seen in Tay-Sachs disease. So can you tell me an enzyme which is absent in Tay-Sachs disease? We all know, right? So Tay-Sachs disease occurs because of ganglioside deficiency, because of the accumulation of gangliosides. So we all know the Tay-Sachs disease occurs because of the accumulation of gangliosides. And here you will say myelin figures. So gangliosides, Tay-Sachs disease, myelin figure. So bhaiya yaad rakh lo, my-tau ka gang. It's not Tay, it is tau. My-tau gang. Right? Very good, Abhishek. So my-tau gang. So it's not Tay, it's tau. So my-tau gang. Do you remember? My for myelin figures. Tau is Tay-Sachs disease, and gang for gangliosides accumulation. So my-tau gang. Very good. Along with the cherry red spot. Very good, Pranav. So remember, my-tau gang. Myelin figures, tau, and gang is for gangliosides. So now don't forget, Gaucher's disease, POP, positive stain, crumpled tissue from cytoplasm. Niemann-Pick's disease, pick zebra bodies and foamy cells on the light microscopy. And Tay-Sachs disease will have multiple myelin figures in the electron microscopy. Right? Okay, guys. Okay, guys. So this was all about the third question. And I know most people have made it right. Don't forget, osmium. Osm is Kamal, CML, pseudo-Gaucher cell, and POP is for the Gaucher cells. Okay, guys. So that brings us to the fourth question. From the immunology chapter, I have tried to bring from one single chapter. So we have discussed the immunology part, inflammation part. Now about the immunology question. All the fact-based question. Let's see who makes the right statement. Most of them are the fact-based questions. Let's see who has a bang-on knowledge here. Which of the following are correct about graft rejection except? All of the following are correct except. So which one of the following is a false statement? Very good. Abhishek, very good. Bhavna, very good. Very good, Riddhi. Bang on, guys. Bang on. The answer is second. We all know hyperacute graft rejection is not example of type 3, but it is example of type 2 hypersensitivity reaction, right? Type 2 hypersensitivity reaction, not the third one. Okay, guys. Okay, very, very important. I'm very good. All of you have made it to the right answer. It is type 2. Very good, Pranav. So before that, make sure you know the other important points. So remember, guys, first MCQ. Hyperacute graft rejection is most commonly seen with renal transplant. Hyperacute graft rejection is most commonly seen with renal transplant. Absolutely correct statement. Next, most common tumor after transplantation. Make sure you know the fact. Most common tumor of skin after organ transplantation is squamous cell carcinoma skin. Just write the fact, okay? So most common tumor after transplantation is squamous cell carcinoma skin. Okay. Now about GVHD. Most commonly associated with allogenic bone marrow transplant. Absolutely correct statement. Absolutely correct statement. GVHD associated with allogenic bone marrow transplant. So quickly revise, right? So when I talk about the graft rejections, in 1 minute, let's discuss all the point. We have this hyperacute graft rejection. We have this acute graft rejection and chronic, right? So we all know hyperacute rejection within minutes to days. Within minutes to days, the reaction will occur. Acute with weeks to days. So minutes to hours, sorry. Here minutes to hours. Here weeks to days. Sorry, days to week. I'm writing all opposite here. Acute will seen within few days to weeks. And chronic, of course, will take weeks to months. Weeks to months or months to year will take months to years, right? So important is, come on, hyperacute rejection is most commonly seen with first MCQ, renal transplantation reaction. It occurs due to preformed antibodies. It occurs due to preformed antibodies. It occurs due to preformed antibodies, and most common antibody which is involved is IgM type antibodies. Right? So within minutes to hours is hyperacute. Most commonly renal transplant occurs due to preformed antibodies, and it is IgM type of antibodies. And on the light microscopy, you will have fibrinoid necrosis. You will have fibrinoid necrosis along with the neutrophilic infiltration. Along with the neutrophilic infiltration. So fibrinoid necrosis and neutrophil accumulation, that is seen in hyperacute renal transplant rejection, right? Okay, and a type of hypersensitivity, type 2 hypersensitivity reaction. Acute, we all know, acute is example of both type 3 and type 4. So we all know, right? Type 2 and type 4. So we all know acute can be either humoral or can be either cellular. Can be humoral and cellular. Humoral is example of type 2. Cellular is example of type 4 hypersensitivity reaction. Right? And important is to know this fact that acute humoral rejection is also called as rejection vasculitis. Is also called as rejection vasculitis. Acute humoral rejection is called as the type 2 rejection vasculitis. Right? And last, chronic is again example of both type 2 and type 4 hypersensitivity reaction. Right? Example of both type 2 and type 4 hypersensitivity reaction. And here again the feature will be the scleroderma like picture. Clinically you will have scleroderma like picture. You will have scleroderma-like picture here. So we'll have scleroderma-like picture because of the entire fibrosis. Because of the entire fibrosis of the organ, you will have scleroderma-like picture, right? So, okay. So this was the hyperacute graft rejection and acute, right? So type second, acute, both type second, type 4. Chronic is again example of both type second and type 4 hypersensitivity reaction, and chronic will give you fibrosis, right? Okay. Now, one more point about GVHD. Because we mentioned the word GVHD, so we all know GVHD is seen in allogenic bone marrow transplant. 2 points about GVHD. It is seen in bone marrow transplant reaction. And we all know GVHD, come on, the recipient and the host. We all know the recipient is immunocompromised. The recipient is immunocompromised and the donor is immunocompetent. That is what happened in bone marrow transplant. You do the conditioning, you kill all the cells of the bone marrow. So patient's immunity is very weak. So immunocompromised recipient and immunocompetent donor. Okay. So we all know about the GVHD, acute and chronic. Acute and chronic. Come on, tell me, acute GVHD is seen when the reaction occur within the 100 days. Within the 100 days, acute. After 100 days, it is chronic rejection, right? It is chronic GVHD. Acute is within less than 100 days. Chronic is above 40 days. Now tell me in acute. Tell me the most common organs involved. Tell me the organs involved in acute GVHD. Can anybody tell me the most common clinical manifestation of GVHD? Come on, most common manifestation of GVHD. Remember guys, there are 3 organs which are involved in GVHD, and that you can remember is with the mnemonic LED. So liver will be involved. E for enteritis will occur. E for enteritis and D for dermatitis. D for dermatitis. So liver, enteritis, that is intestinal inflammation, and dermatitis. Because of the liver involvement, this will have jaundice. Jaundice. Nahi baba, nahi shubham, nahi. Enteritis will give you diarrhea. Diarrhea, and dermatitis will give you maculopapular rash. So maculopapular rash like sunburn. So they will give you sunburn like picture. They will give you sunburn like picture. So remember, maculopapular rash on the skin. Because of intestinal involvement, there can be bloody diarrhea. Diarrhea can be bloody diarrhea. This is how they'll make a clinical case, guys. And liver is jaundice. And remember, it is the skin manifestation which is the most common manifestation of GVHD. So skin involvement is the most common involvement in GVHD, man. Remember, it is skin involvement which is the most common involvement. So LED, liver, enteritis and dermatitis. Okay. And chronic, we all know there will be fibrosis. There will be all fibrosis. Right? Okay, guys. So now don't make a mistake. The days have been asked, less than 100 days. And the most common organ involvement, it is skin. No, it is not renal, guys. It is the skin which is most commonly involved in acute GVHD. Okay, now. So one last point that I want to add on here is, guys, we all know bone marrow transplant. Bone marrow transplant will increase the chances of GVHD. Just a old NEET MCQ. Can you tell me what is the most common complication of bone marrow transplant or hematopoietic stem cell transplant? Can anybody tell me? Can you recall hematology? What is the most common complication of bone marrow transplant or hematopoietic stem cell transplant? Can you tell me? It is not GVHD. Remember, don't get mistaken. It is immunodeficiency and infections by cytomegalovirus. It is the infections by cytomegalovirus which is overall the most common complication of hematopoietic stem cell transplant. So remember, it is not GVHD. So don't get confused. Yes, GVHD is seen after bone marrow transplant. Most common cause of GVHD is, yes, allogenic bone marrow transplant. But most common cause, most common complication of stem cell transplant is not GVHD. It is infection by cytomegalovirus. Okay, guys. Okay. So done. So remember this point. Okay. So now done with the point. Of course, GVHD is right statement, but the wrong statement is the D one, right? Okay, guys. Okay. Next question. Again, match with the following. Easy, nothing to tell you. ISC markers. I'm sure everybody will make a correct statement. Come on, guys, everybody. Jyothiram, very good, Bhavana. Very good, guys. Easy question. Not easy. See, there is no easy and difficult, man. It is all about what you can retain and what you cannot. Very good, guys. Very good. All of you have made it. Yes, Shubham. Shukra Bhagwan ka tu theek hua. Very good, Abhishek. Yes, guys. CD99 is for Ewing sarcoma. CD99 Ewing sarcoma. A is C. HMB45 is for malignant melanomas. Very good, everybody. Desmin is for rhabdomyosarcomas. And arginase 1 is a very specific marker for hepatocellular carcinoma. Very good, Soumya, Shri Ram, Abhishek. Everybody bang on, man. So remember about all this thing. Nothing to tell you. CD99 Ewing sarcoma. Can you tell me one more cancer which is positive for CD99? CD99 granulosa cell tumor. Granulosa cell tumor. So granulosa cell tumor is also positive for CD99, right? Okay. So CD99 Ewing sarcomas, very, very important. Remember about CD99 is also called as MIC2. CD99 is also called as MIC2 and it is positive for both Ewing sarcoma and granulosa cell tumor ovary. So CD19 is positive for both granulosa cell tumor ovary. Right? Okay. कुछ नहीं होता शुभम, कुछ भी याद आना चाहिए. बहुत बढ़िया. Okay. HMB48 malignant melanoma. Very good, guys. All of you made it. HMB40. Very good, शुभम. अगर तुझे उससे याद आ गया, high five, buddy. Very good. So malignant melanoma, right? Malignant melanomas. Remember, most specific marker is HMB45. Most specific for melanomas is HMB45, and most sensitive for malignant melanoma is S100. S100. So remember about melanomas, always have been a hot topic. Specific is HMB45. Sensitive is S100. Other we can use is Milan A. Also we can use this Milan A for melanomas. Also we can use Milan A. Also we can use is Milan A. So remember malignant melanomas, most specific is HMB45 and sensitive is S100. S100. Shubham is telling us that S100 is also seen in Langerhans cell histiocytosis. Bilkul, boss. Very good. It is also seen in. So S100, don't get confused. S100 we have already studied. It is also seen in schwannomas. It is also seen in schwannomas. It is very non-specific one, right? Schwannomas. It is also seen in Langerhans cell histiocytosis. Right? So, okay. But remember, S100, schwannomas and Langerhans cell histiocytosis. But also remember, S100 is again a sensitive marker for melanomas also. Right? So 2 points. CD99, MIC2 for granulosa cell tumor and Ewing sarcoma. Melanomas we discussed, specific is 45 and sensitive is S100. Okay, very good. Okay. So that will bring us to the next question. Now hemat. Done with neoplasia, done with immunology, inflammation, cell injury. Coming to the hemat part. Okay. Read the question carefully and then tell me the answer, guys. Yes. So, first of all, diagnosis, guys. Diagnosis and then the answer. Very good, Jyoti. Very good. Yes. So, the diagnosis is 11-14 diagnosis is. See, very good, yeah, guys. These are not an easy question. If you all are making it right, that means you are right. Dr. Turtle. Turtle. Marginal is 11-18 turtle sahab. Marginal is not 11-14. It is 11-18. Marginal or maltomas. This is for you, Dr. Turtle. It is 11-18 and not 11-14. Right? It is 11-18. 11-14 is for mental cell lymphoma. 11-14 is for the mental cell lymphoma. Very good, guys. So it is for the mental cell lymphomas. Mental 11 yaar. 11-14 if you okay. So 11 is for mental, right? Ek aur ek 11. Itna 11 will become mental. And 11-18 is for marginal zone lymphoma. Now we all know answer is A and B only. That is the SOX11 and cyclin D. So quickly revise about mental cell lymphomas. So we all know it is seen after 60 years of age. Right? Most common symptom of mental cell lymphoma, remember cervical lymphadenopathy. So all the probable MCQs about mental cell lymphomas, it is cervical lymphadenopathy, right? And most characteristic symptom, most characteristic feature about mental cell lymphoma is lymphomatoid polyposis. Lymphomatoid polyposis. Most characteristic is lymphomatoid polyposis, that we all know. Very good, Abhishek, very good. That is the tumor cells. The tumor cells infiltrate the intestinal mucosa. The tumor cells infiltrate the intestinal mucosa, that is lymphomatoid polyposis, seen in mantle cell lymphoma. Now about the diagnosis of mantle cell lymphoma, we all know we have first of all cytogenetics. We have cytogenetics and immunopathology. We have cytogenetics and we have immunopathology. Cytogenetics, we all know it is seen because of 11 and 14 translocation, and because of 11-14 translocation there is overexpression of cyclin D. अरे मेंटल पागल हो गया, मेंटल साइकिल पे घूमने लगा भैया. Cyclin D. So cyclin D also called as BCL1, cyclin D or BCL1, and right. So we have increased cyclin D overexpression, and but in cyclin D negative people, so the one who are negative for cyclin D, in cyclin D negative people, we have SOX11 as the best marker, which is overall the best marker for mantle cell lymphoma. Yes, very good, Pratham, very good. So cytogenetics, cyclin D, in cyclin D negative people, it is the SOX11 which is the best marker, right? Now about the immunopathology. Immunopathology, we all know it is CD5 positive and CD23 negative. CD5 positive and CD23 negative. Very good, very good. So remember, immunopathology is CD5 positive, CD23 negative, and cytogenetics is 11-14, that is increased cyclin D. फटाफट मुझे बता दो, come on. CD5 positive, CD23 positive. Both are positive for, yes, chronic lymphoid leukemia. CLL. So CLL is for CD5 and CD23, right? Now, I told you cyclin D is also called as BCL1. We are here to quickly revise the session. Cyclin D is BCL1, right? Cyclin D is BCL1. Now tell me BCL6. Okay, first of all, BCL2. Yes, BCL2 is seen in follicular lymphomas. BCL2, follicular lymphomas. BCL6, come on, BCL6. Yes, guys, DLBCL also in Burkitt's lymphoma, also can be seen in Burkitt's lymphoma, right? So BCL2 is for follicular, BCL1 is cyclin D, that is for mantle cell lymphoma, BCL2 follicular, BCL6 is for DLBCL or the Burkitt's. Very good, very good. Okay, guys. So coming to the next question. Okay, coming to the next question from the hemat part. Very good, Jyoti. बहुत अच्छे, very good here. There is, I again repeat, there is nothing called as easy or difficult. It's all about how much you retain, guys. And if you're able to retain here, you'll retain everything, man. Very good, guys. Posterior mediastinal mass 5 into 6 centimeter mediastinal mass, scattered large multinucleated cells with prominent nuclei which are positive for CD15. CD15 large multinucleated cells. CD15 and multinucleated cells. CD15 again going in favor of Hodgkin's lymphoma. Okay. Hodgkin's lymphoma, CD15, prominent nuclei, multinucleated cell, Hodgkin's lymphoma, macrophages separated by dense collagenous band. Very good, Pratham. Pratham, ये champ man. Pratham, Bhopal Jindabad, bhaiya. Pratham, Bhopal Jindabad. Yes, very good SMS. It is the lacunar cells. It is the lacunar cells. Okay. So they are talking about, yes. So lymph node, mediastinal mass, multinucleated cell with prominent nuclei along with CD15 positive. So one thing for sure is multinucleated cells along with CD15 positivity, they are talking about Hodgkin's lymphoma. Very good, Soumya. Yes, Pratham. Hodgkin's lymphoma. Now, which variant? Separated by dense collagenous band. Which variant? Nodular sclerosis. Which variant, guys? They are talking about nodular sclerosis. And we all know in nodular sclerosis, see, the catch point here is separated by dense collagenous band. So they are talking about the nodular sclerosing variant, and we all know the nodular sclerosing variant again belongs to the classical Hodgkin's lymphoma. Classical Hodgkin's lymphoma. So we all know classical are positive for CD15 and CD30. So classical are, because it belongs to classical Hodgkin's lymphoma, so CD15 and CD30. Come on, non-classical. The non-classical one, they are positive for, the non-classical one are positive for, yes, come on, CD20, CD45 and BCL6 and BCL6. So classical 1530, non-classical 20, 45 and BCL6, right? Now about the nodular sclerosing variant, right? About the nodular sclerosing, we all know the nodular sclerosing variant is seen in, very good Richpal, very good Parikshit, very good Abhishek. So nodular variant, we all know it is seen in young people, it is seen in young age, and we have this lacunar cells here. We have the lacunar cells here, right? Lacunar cells here, young age lacunar cell, and along with the best prognosis. And along with the best prognosis, right? Among the best prognosis among the classical one. Best prognosis among the classical one, that is nodular, right? That is nodular, right? So easy, right? So we all know, bhaiya, sclerosis means collagenous band. That is obvious. Sclerosis means there is presence of collagenous band. And we all know, bhaiya. So yes, lacunar cells means, so these are the lacunar cells. We all know, right? So these are the lacunar cells with the foamy cytoplasm, guys. You also this foamy cytoplasm, this clear cytoplasm, this entire empty cytoplasm. This is called as the lacunar cells. So white cytoplasm, right? Empty. And why I'm writing white? So that you can remember it. Empty is white. And why white? What is the significance of white? We all know sclera. Sclerosis has sclera. And what is the color of sclera? The layer of the eye, the color of the sclera is white. So remember, sclera is white. So the cells, the cytoplasm will also be white. White means clear. Lacunar cytoplasm. Lacunar is empty. So name is telling sclera is white. So white cytoplasm. And of course, we all know sclera is the outermost layer of the eye, which is very strongest layer. So strong, that means young people. So it will occur in strong people only. That is the young people, and they have the best prognosis one. Right? So remember, lacunar cells are seen in white, that is sclerosis. Come on, tell me, popcorn cells, quickly revise. The popcorn cells are predominantly seen in NLPHL. We all know, right? The popcorn cells are seen in nodular lymphocytic predominant Hodgkin's lymphoma. Popcorn cells, lymphocytic, nodular lymphocytic predominant. So P is for popcorn, right? P4 is for predominant, and P4 is the popcorn. And we all know overall best prognosis is of NLPHL. Overall best prognosis is of NLPHL. Overall best prognosis is of NLPHL, right? Okay, guys. Okay. So quickly revise one thing about the cells. So we have discussed, right? So popcorn cells, lacunar cells in the nodular sclerosing variant, popcorn cells in NLPHL. And where you will see mononuclear cells predominantly? Mononuclear cells, remember, mixed cellular variant. So M for M, mononuclear cells are seen in mixed cellular variant. And mummified cells or pleomorphic cells are seen in, come on, mummified cells or pleomorphic cells, anaplastic cells are seen in lymphocytic depleted variant. Just make sure you know all the questions. So here we discussed about just the lacunar variant. So in that we covered everything. Lacunar white, that is sclerosing variant. Now P for P, popcorn will be seen in predominant one, right? Now mononuclear cells, just remember M for mononuclear, M for mixed cellular one. M for mononuclear, M for mixed cellular one. Whereas the lymphocytic depleted, we all know lymphocytic depleted has the worst prognosis. The lymphocytic depleted has the worst prognosis. Now worst prognosis will have the most bizarre cells, that is the mummified and the pleomorphic cells. Pleomorphic, anaplastic cells, mummified cells are seen in the worst prognosis one, which is the lymphocytic depleted variant, right? Okay, guys. Okay, done, man, done. So next question, guys. Okay, time for the next question. Okay, moving to the 8th question. Very good. Looking at your response, very good. So okay, diagnose the disease and then tell the correct statement. Read yourself and then correct statement. peripheral neuropathy as well as hypertension. Peripheral neuropathy, hypertension. Angiography demonstrates multiple aneurysm in the renal artery. Past medical history of hepatitis B. Biopsy shows transmural necrotizing vasculitis and fibrinoid necrosis. Tell me which vasculitis are they talking about? First of all, diagnosis of the disease, guys. Come on, which vasculitis are they talking about? Peripheral neuropathy. Very good, Surya, Jyoti. Very good, Pratham, Abhishek. Very good, man. Yes, they are talking about polyarteritis nodosa, right? So they are talking about PAN. So now you can easily see history of hepatitis B, first catch point. Then renal artery involvement, second catch point, right? Then we all know from pathology, right? So transmural necrotizing vasculitis and fibrinoid necrosis. Seen in all these are the feature of polyarteritis nodosa. I don't know why people are telling C. Parikshit, why Sid, why going for C? They are talking about the correct statement. So is the PNK antibodies raised? Pratham, C is A the right answer. You have granulomas there? Will you see granulomas as a characteristic feature of PEN? No, man. So come on, tell me the example of granulomatous vasculitis. That will be a good point. Tell me an example of granulomatous vasculitis. Pratham, why, buddy, why? Granulomatous vasculitis. Yes, we have giant cell arteritis. We have, come on, Takayasu arteritis. We have vaginous granulomatosis. And we have Church-Strauss syndrome. These are the example of granulomatous vasculitis, guys. Why will you see granulomas? Pratham, they are asking the correct statement. So first is a false statement. You will not have granulomas, but you will have on the biopsy transmural necrotizing inflammation and fibrinoid necrosis. So remember, see, this way we have understood all the four conditions where you see granulomatous vasculitis. Remember this point, very, very important. Granulomas, giant cell, Takayasu, vaginous and Church-Strauss. Now cysts are seen in lung. Can it be a right involvement? Can it be a right question? Do you see pulmonary involvement in pulmonary artery nodosa? No, man. So this is not a correct statement. Cysts are not seen in lungs. You don't see pulmonary involvement in the pulmonary artery nodosa. In PAN, you don't see pulmonary involvement. That cannot be right answer. No PNK antibodies. No PNK antibodies. We all know PNK antibodies are raised in microscopic polyangiitis. Microscopic polyangiitis, right? Right. Now, all stages of the activity. Yes, this is the right answer, man. This is the correct statement. All stages of activity may coexist. So, acute, all stages of activity may coexist in different vessels or with the same vessel. Okay, D is the correct statement. Okay, yes, Pratham, D is the correct statement. Polyarteritis nodosa will have all the acute and chronic lesion which coexist. So acute and chronic lesion may coexist in the same vessel or in the different vessel at the same time. So this is a catch point about pulmonary artery nodosa. So remember all the 3 points. Why you have made answer C? So first of all, 3 things about pulmonary artery nodosa. Can you recall, people who have studied from me, can you recall PNK antibodies? Yes, we all know the mnemonic of PNK antibodies. Tell me conditions where you will see PNK antibodies. Come on, you all can recall it. Yes, Turtle. I'm talking about PNK. PNK mnemonic is good CM. Conditions where you will see raised PNK. G for good pasture syndrome. U for ulcerative colitis. D for drugs like hydralazine. Drugs will give you PNK. C for Church-Strauss syndrome. And M for microscopic polyangiitis. Good CM. Very good, Shubham. Good. You'll become a good CM. So where does polyarteritis nodosa come here? So polyarteritis nodosa, no P involvement. No P involvement, right? So remember, this is the condition. The people who have not studied from me, remember, good CM is the mnemonic for PNK. And last, so again, see peripheral neuropathy. Can you tell me a lesion? A characteristic neuropathy. What do you call this type of neuropathy? Yes, if you can recall, mononeuritis complex. This type of neuropathy is seen with mononeuritis complex. This type of neuropathy is called as mononeuritis complex. So we all know the most common vasculitis associated with mononeuritis complex, which is a type of peripheral neuropathy. This is seen in PAN, the polyarthritis nodosa. Polyarthritis nodosa. This type of neuropathy is called as mononeuritis complex. So remember, mononeuritis complex is associated with polyarthritis nodosa. And you have forgotten, the people who have not studied, see the name is telling. See the name is telling, I told you, right? No, PAN stands for polyarthritis nodosa. No, it stands for pulmonary artery not involved. Pulmonary artery not involved. These are for the people who have not studied from me systemic path. Pulmonary artery not involved. PAN. Again, PAN stands for no PNK. PNK not increased. So PAN, the name is telling. PAN, pulmonary artery not involved. That is no pulmonary involvement. And PNK not raised. PNK is not raised. Pulmonary artery, that means no pulmonary involvement is seen in PAN. And one more thing, if you can remember by PAN only. So PAN, no. Peripheral neuropathy is seen. PN. So you can see peripheral neuropathy. But no, but you will not see pulmonary artery involvement. PN, pulmonary artery not involved. PNK not involved. But you will have peripheral neuropathy. You can have peripheral neuropathy, but you cannot have other two conditions. Right? So I'm sure you all would have made it. The answer is D. Right, guys? Okay. Next question, man. Next question. So second last MCQ. So good CM, remember the mnemonic, and PAN, pulmonary artery not involved. PNK not increased, and PAN, you will have peripheral neuropathy. Okay, guys. Next question. If you can see the images. Very good, guys. Very good. Very good. So this is for the images. If you can recall. अरे systemic path तो तुमने आग लगा दी भैया. Very good, man. I'm very happy to see that none of you are making any mistakes in the systemic path. Very good, guys. So what do you see here? The cells with, yes, fried egg appearance, right? A perinuclear clearing. The clear cytoplasm is what you see here, right? All the clear cytoplasm is what you see here, guys. So perinuclear clearing, fried egg appearance, along with the lymphocytes in the septa, right? Look at the image again, guys. You see all the clear cells, the cells with the clear cytoplasm, and again you will have this lymphocytes in the septa. So clear cytoplasm due to presence of glycogen, and again lymphocytes. So again what you can see is again a fried egg appearance, what you call it. Also you call it fried egg appearance, right? And presence of lymphocyte in the fibrous septa. Presence of lymphocytes. So another catch point, right? Come on. So what is this question saying? Normal age is young age, then painless testicular enlargement, testicular mass, HCG normal, alpha fetoprotein, and increased level of placental alkaline phosphatase. So we all know all these are the placental alkaline phosphatase and LDH. They are the marker of seminomas, and on the images you will have this characteristic clear cytoplasm. Very good, Abhishek. Very good, man. And lymphocytes. So quickly 2 points about seminoma, guys. 2 points about seminomas. Yes, come on, tell me. Age is again 15 to 40 years. 15 to 40 years. Can you tell me the tumor markers of seminoma? Tumor markers of seminoma. Yes, it is LDH. Then we have PLAP, the placental alkaline phosphatase, and also you can have beta HCG. Although in this question it was normal, but you can have beta HCG in 15% of the cases. So LDH, PLAP, and beta HCG in 15% of the cases. These are the tumor markers of seminomas. About the molecular markers, guys. About the molecular markers, we all know OCT3-4. Remember, 3rd 4 अक्टूबर को नाना जी के पास कलरफुल किट पहन के नैनो जी एंड सी किट. So कलरफुल किट पहन के 3rd 4th अक्टूबर को हम नाना जी से मिलने गए थे. C kit, colorful kit, 3rd, 4th October, Nano G. So OC3 for Nano G and C kit is the molecular markers for seminomas. Right? So okay, and cells we have already seen. On the light microscopy, we have this fried egg appearance. The cell with the clear cytoplasm containing glycogen. So because of the glycogen clearing of the cytoplasm, which gives you fried egg appearance. And yes, again, the septa will have lymphocytes. Separated by the septa, which consist of lymphocytes. Okay, man. Okay. So remember, so this was about the seminomas. Why then? About the why not York sac tumor. So 2 point about York sac tumor. Very, very important for the exam. York sac tumor, remember, age. York sac tumor seen in children, normally less than 3 years of age. Can you tell me the light microscopy of York sac tumor? Yes, we have Schiller-Duval bodies. And the tumor markers. Guys. Tumor markers is, yes, alpha fetoprotein and alpha 1 antitrypsin. So age is different, less than 3 years. Light microscopy, Schiller-Duval bodies. Tumor marker is alpha fetoprotein and it is alpha 1 antitrypsin, right? Okay. So just remember York sac tumor. The name is telling York sac. They are telling York sac. As for it will have Schiller-Duval bodies. A for alpha 1 antitrypsin and alpha fetoprotein. And C for it is seen in children. So no doubt about that. York sac, remember sac, Schiller-Duval bodies, alpha 1 antitrypsin, alpha fetoprotein and children, right? And children. So this is about York sac tumor. Okay, guys. Okay, done. Don't forget about York sac, the C sac of York sac tumor. Okay, now next question, guys. The last question of the today's session. I'm sure you all will take it out, guys. The way you are responding to systemic pathology, I'm very, 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 very happy to see this, man. Very good, guys. So the microscopic feature of chronic hepatitis. Come on, who have studied from me? Come on, tell me the mnemonic of chronic hepatitis, guys. Tell me the mnemonic of chronic hepatitis. Very good, Shubham. Very good, man. Very good. All of you, bang on, guys. Very good. Can you tell me the mnemonic? Yes, the answer is ballooning degeneration. All of the following are the feature except, yes, ballooning degeneration is seen in acute hepatitis. So can you recall what is the mnemonic for chronic hepatitis? Yes, a famous game called as PUBG. You have a famous game. All the microscopic features of chronic hepatitis. Very good, Shubham Pratham. Very good. It is PUBG. Quickly revise, guys. P for we have piecemeal necrosis. U for come on. C, we have piecemeal necrosis. Done. U for come on. Ultra lymphocytic infiltrate. That is the lymphoid follicles in the portal tract. So ultra lymphocytic infiltrate in the portal tract leading to portal tract expansion. B for we have bridging fibrosis. I'm glad everybody you can recall the mnemonic. And G for we have ground glass hepatocytes. So PUBG is the mnemonic for the chronic hepatitis, guys. Piecemeal necrosis, ultra lymphocytic infiltrate in the portal tract, bridging necrosis and fibrosis, and ground glass hepatocytes. So quickly revise, guys. Piecemeal necrosis, we all know it is also called as interface hepatitis. Right, I'm glad all of you can make it, man. Interface hepatitis. It is a necrosis of the limiting plate. Ultra lymphocytic infiltrate in the portal tract. This is, come on, Pratham, Abhishek, Shubham. Come on. Jate dil mat todna. Ultra lymphocytic infiltrate in the portal tract leading to portal tract expansion. This is characteristic feature of chronic hepatitis. B or C? Yes, it is seen in chronic hepatitis C virus. A very characteristic feature of hepatitis C virus is the portal tract expansion by lymphoid follicles. right? So in a chronic hepatitis C virus, we all can remember chronic hepatitis C, we have lymphoid follicles. We have lymphoid follicles in the portal tract along with macrovesicular steatosis. If you can remember this, guys, very, very important for the exams. Macrovesicular steatosis and lymphoid follicles. These are seen in chronic hepatitis C virus. So remember two microscopic feature of chronic hepatitis C: lymphoid follicles in the portal tract and macrovesicular steatosis. And last, ground glass hepatocytes. We all know ground glass hepatocytes. It's seen in chronic hepatitis B virus. So chronic hepatitis B will have ground glass hepatocytes. It is because of the presence of HBs antigen in endoplasmic reticulum of hepatocytes. Endoplasmic reticulum of hepatocytes, right? So ground glass hepatocytes, chronic hepatitis B, HBs antigen, endoplasmic reticulum of hepatocytes, and chronic hepatitis C, lymphoid follicles and macrovesicular steatosis. Right? Okay, so macrovesicular steatosis is seen in chronic hepatitis C virus. Great, man. Done. So done, guys. I have taken 1 hour of yours, but trust me, looking at the response of you guys, it was blessing, man. It was blessing to have you guys. Great. मुझे तो नींद अच्छी आएगी. Thank you so much, and understand the depth of this 10 questions. General path, hemat, seismic path all together. All of you made it, man. All of you made it. Glad to mix. I made all the cocktail, but you people bang on, man. So thank you so much, guys. So it was the last session from pathology. अरे यार, पढ़ते रहो, आग लगाते रहो. Trust me, all are on very good track, man. Keep studying the way you're doing, man. Do share the valuable feedback with me, man. And that is all from my side. Goodbye. Enjoy. Study well, man. Study well, man. Bye-bye, guys. Thank you so much, Abhishek. This really means a lot to me, man. Thank you so much, man. Goodbye. Good night.